Welcome to the deep dive. Today, we're really zeroing in on getting you ready for the shelf exam and Step2CK.
Uh-huh.
We're diving deep into obstetrics using your own comprehensive study notes.
That's right.
And our mission really is to pull out that critical info and, maybe more importantly, help you connect the dots using realistic clinical scenarios.
Exactly. Seeing it in context.
We're going to cover a lot of ground from early pregnancy changes all the way through labor issues and postpartum stuff. So let's get started.
Absolutely. And what's really key, I think, is understanding how these topics that might seem separate are, actually quite interconnected. We're not just listing facts. The goal is to show you how these things actually present in the clinic, so you start thinking like an experienced physician when you see these vignettes.
Okay, perfect. So let's jump right into an early change. Hematologic adaptations. Your notes mention plasma volume increases.
Yeah.
What's the main takeaway there for looking at lab results?
Yeah, the crucial point here is that the plasma volume expands significantly more than the red blood cell mass does.
Okay.
So you get this physiological dilution effect. It leads to, slightly lower hemoglobin and hematocrit values, maybe even a small dip in platelets.
Mm-hmm.
The key is recognizing this is normal in pregnancy, so you don't jump to conclusions about anemia or thrombocytopenia right away.
Makes sense. Don't misinterpret the normal. Okay, let's tackle hypertensive disorders. Here's a case. A woman, she has known high blood pressure, presents early in her pregnancy. What's her immediate thought process?
Okay, so first thing is we need to distinguish her pre-existing chronic hypertension from gestational hypertension or preeclampsia, which could pop up later.
Right.
Remember the definition for chronic blood pressure, 140/90 or higher, and this is documented before pregnancy or before 20 weeks gestation.
Okay.
And you need 2 elevated readings, at least 4 hours apart, to confirm it. The big concern here is really the potential cascade of effects on both the mother and the baby.
Right. Can you paint that picture for us? What are those potential maternal and fetal complications we really need to have on our radar in this scenario?
Sure. So for the mother, her existing vascular stress puts her at higher risk for things like superimposed preeclampsia, postpartum hemorrhage, gestational diabetes, even placental abruption, and needing a C-section.
Wow.
And for the fetus, that compromised placental blood flow can unfortunately lead to fetal growth restriction, preterm delivery, oligohydramnios, that's low amniotic fluid, and sadly even increased perinatal mortality.
Mm-hmm.
You can kind of think of it like this. The higher systemic vascular resistance and arterial stiffness she already has, that hinders the placenta's ability to function optimally.
Okay.
It's actually the opposite of what you might see in, say, poorly controlled diabetes, where you often get polyhydramnios because the high glucose makes the baby produce more urine.
That's a really helpful contrast. Now, what about white coat hypertension? How does that fit in if we see high readings early on?
Yeah, white coat hypertension is definitely something to keep in the back of your mind, especially if you get unexpectedly high readings in someone who seems otherwise low risk.
Okay.
The anxiety of just being in a medical setting can bump up the pressure temporarily, so maybe consider repeat checks outside the clinic, like with home monitoring, to help sort that out.
Good point.
Yeah.
Okay, moving down the list, gestational hypertension. How's that defined differently from chronic?
Gestational hypertension is basically the new onset of that same high blood pressure, 140/90 or higher, but it starts at or after 20 weeks of gestation.
After 20 weeks.
Right. And crucially, there's no proteinuria and no signs of end organ damage.
Okay. And then preeclampsia kind of builds on that definition. What's the key addition?
Exactly. Preeclampsia is that new onset hypertension at or after 20 weeks, but now you also have either proteinuria,
Okay.
which is defined as more than 300 milligrams in a 24-hour urine, or a protein creatinine ratio of 0.3 or more, or even just a dipstick of 1 plus or higher.
Right.
Or you have signs of end organ damage, things like severe headache, visual changes, abnormal liver enzymes, low platelets, kidney problems.
Got it. Hypertension plus either proteinuria or end organ signs after 20 weeks.
Precisely.
And eclampsia, that's preeclampsia, plus something very specific and serious.
Yes. Eclampsia is simply preeclampsia plus the occurrence of new onset grand mal seizures, where there's no other identifiable cause for those seizures.
Okay, seizures. And finally, how do we spot chronic hypertension that gets complicated by superimposed preeclampsia.
So you'd suspect superimposed preeclampsia in a woman who already has chronic hypertension, but then at or after 20 weeks, she develops new proteinuria, or her existing proteinuria gets worse.
Wow.
Or maybe her blood pressure suddenly gets much harder to control, or she develops any of those signs of end organ damage we just listed.
Okay.
It basically signifies a dangerous escalation because you have the underlying chronic issue plus the new preeclamptic process on top, higher risk.
Yeah. That's a really clear breakdown. Thanks. Let's switch gears now to a common postpartum scenario. Picture this. A woman, maybe 3 to 5 days after delivery, calls reporting her breasts feel really full, tender, maybe even a bit red, and it's on both sides. What's the most likely diagnosis here?
Yeah, that timing, 3 to 5 days postpartum, and the fact that it's bilateral really strongly points towards breast engorgement.
Okay.
This is the time when milk production really ramps up, transitioning from colostrum to mature milk. And physiologically, besides just the increased milk volume, there's a big postpartum drop in progesterone.
Right.
That hormonal shift doesn't just kickstart lactation, it also contributes to some interstitial edema, fluid in the breast tissue itself, which makes that feeling of fullness and tenderness even worse.
So how do we advise her to manage this? What can she do?
The main thing is frequent and effective milk removal. So breastfeeding often, making sure the baby has a good latch, or pumping if breastfeeding isn't happening or isn't enough. Cool compresses can definitely help with the swelling and discomfort between feedings. And then, simple over-the-counter pain relievers like acetaminophen or NSAIDs can take the edge off the pain.
And how can she tell this apart from maybe more serious postpartum breast issues?
Good question. It's important to differentiate. So lactational mastitis, that's usually unilateral, just one breast, with a distinct wedge-shaped area of redness and tenderness, and often comes with a fever. Feels like the flu sometimes.
Okay, unilateral and fever.
Right. A breast abscess would typically present as a fluctuant, palpable mass. You can feel fluid under the skin, maybe with swollen lymph nodes in the armpit. Mammary candidosis, or thrush of the nipple, often causes this really sharp stabbing, kind of burning pain, sometimes with shiny or flaky nipple skin, usually unilateral too.
Okay.
And then a galactocele or a plug duct usually feels like a specific firm lump, but without all the diffuse swelling and systemic symptoms you might see with engorgement or infection.
Got it. Are there situations where breastfeeding just isn't recommended? Contraindications.
Yes, absolutely. There are definite maternal and infant situations. For the mother, active untreated tuberculosis is a contraindication. HIV infection, in developed countries where safe formula is readily available, is generally considered a contraindication.
Right.
Also, active herpes, simplex lesions on the breast itself, active varicella infection, ongoing chemotherapy or radiation, active substance abuse, and also cracked or bleeding nipples if the mother has hepatitis B or C, at least until those lesions heal. For the baby, the main one is galactosemia, a metabolic disorder.
Okay.
And it's really crucial to counsel mothers about cocaine use. Cocaine gets into breast milk and can cause severe toxicity, seizures, even withdrawal in the infant. Very dangerous.
Okay, very important points. Let's move to a different type of pregnancy complication. Molar pregnancy. So imagine a woman presents, she's got irregular vaginal bleeding, her uterus feels maybe larger than you'd expect for her dates, and she's got severe nausea and vomiting.
Yeah.
What should be high on her differential diagnosis?
Yeah, that cluster of symptoms, abnormal bleeding, a uterus that's large for dates, and hyperemesis, that's a classic triad that should make you immediately suspicious for a high datiform MOLA, or molar pregnancy.
Okay.
We should also think about risk factors. Things like extremes of maternal age, so very young or older, a history of a previous molar pregnancy, possibly vitamin A deficiency, and maybe a history of infertility.
What other clues might we find either on exam or in her history that point towards a molar pregnancy?
Well, she might report passing tissue that looks like small grapes. Those are the abnormal hydropic villi.
Grape-like.
Right. Lab-wise, a markedly elevated beta-HCG level is a huge clue, much higher than you'd expect for a normal pregnancy of that gestation.
Okay.
You might also find bilateral ovarian cysts on ultrasound called the scota-lutein cysts. These are caused by the ovaries being overstimulated by those super high HCG levels.
Right, HCG stimulation.
And sometimes you can even see signs of hyperthyroidism because HCG can weakly stimulate the TSH receptor or even preeclampsia with severe features, but developing before 20 weeks gestation.
Preeclampsia before 20 weeks, that's a major red flag, right?
Huge red flag. Preeclampsia almost never happens before 20 weeks in a normal pregnancy. If you see it early, molar pregnancy should be very high on your list because that abnormal placental tissue is causing problems early.
So how do we confirm the diagnosis, and what's the standard management plan?
Diagnosis relies heavily on that quantitative serum beta-HCG level. Again, it's usually extremely high, and a transvaginal ultrasound.
Okay.
The ultrasound often shows this characteristic snowstorm appearance, or sometimes described as a cluster of grapes, filling the uterine cavity, typically with no fetus visible in a complete mole.
Snowstorm appearance. Got it.
Definitive diagnosis comes from histology, examining the tissue after it's removed. Management is uterine evacuation, usually by dilation and suction curettage. Right. And then, critically, close follow-up is essential. Serial beta-HCG levels are monitored, typically weekly, until they become undetectable. Then monthly for about 6 months.
Why the close monitoring?
To watch for the development of gestational trophoblastic neoplasia, or GTN, which is a malignant progression that can occur after a molar pregnancy, reliable contraception is also crucial during this surveillance period.
Okay. And you mentioned differentiating this from something like embryonal carcinoma.
Yeah, that's another rare tumor that produces beta-HCG, but it usually doesn't present with that same uterine size discrepancy or early preeclampsia. You might see other findings like ascites. It's a different entity.
Okay, good distinction. Let's quickly touch on the biophysical profile, the BPP. What are the 5 components we're assessing?
Right. The BPP looks at 5 indicators of fetal well-being. There's the non-stress test, or NST, looking at fetal heart rate reactivity.
Okay.
Then 4 things on ultrasound: amniotic fluid volume, gross fetal body movements, fetal tone, and fetal breathing movements. 5 components total.
And what's considered a normal finding for each of those? How do we get that max score of 10?
Okay, so for a normal or reassuring result, you get 2 points for each. A reactive NST gets 2 points. Adequate amniotic fluid, usually defined as a single deepest vertical pocket of at least 2 centimeters, or an AFI greater than 5, gets 2 points.
Right.
At least 3 distinct body or limb movements gets 2 points. At least 1 episode of active extension with return to flexion of a limb or the trunk, that's fetal tone, gets 2 points.
Okay.
And at least 1 episode of fetal breathing movements lasting for at least 30 seconds within a 30-minute observation period gets the final 2 points. Add them up, max score is 10.
Perfect. Your notes also mentioned the Wicca lutein cysts again. What's the clinical significance if we happen to see those on an ultrasound?
Finding those bilateral, often quite large multilocular ovarian cysts, typically 10-15 centimeters, should definitely make you think about conditions associated with really high beta-HCG level.
Like the molar pregnancy.
Exactly. Molar pregnancy is number 1. But also things like multifetal gestations, especially twins or triplets, and sometimes ovarian hyperstimulation syndrome from infertility treatments.
Okay.
The good news is these cysts are benign, and they typically resolve on their own as the HCG levels come down.
Okay, that's reassuring. Now, let's shift to a major postpartum emergency, uterine atony. Here's a scenario. A woman starts bleeding heavily right after delivery. You examine her, and her uterus feels soft, maybe boggy, and enlarged well above the umbilicus. What's our top concern?
That is the absolute classic presentation for uterine atony. It's by far the most common cause of primary postpartum hemorrhage that's bleeding within the first 24 hours.
Okay, most common cause.
Right. Normally, after the placenta delivers, the uterus clamps down hard. Those contractions compress the blood vessels where the placenta was attached and stop the bleeding.
Makes sense.
In uterine atony, the uterus just fails to contract effectively. It stays soft and boggy, and those vessels keep bleeding.
So what makes the uterus fail to contract like that? What are the risk factors or causes?
Several things can contribute. Uterine muscle fatigue is a big one, maybe from a very long labor or an induced labor, especially with prolonged oxytocin use.
Okay.
Overdistension of the uterus is another major factor. Think about a large baby, like over 4,000 grams, or twins, triplets, or polyhydramnios, too much amniotic fluid. The stretched out muscle just can't contract down as well.
Right, overstretched.
Exactly. Other things include operative delivery like forceps, hypertensive disorders, infection like chorioamnionitis, having had many babies before grand multiparity, and sometimes a retained piece of placenta can prevent good contraction too.
So we suspect atony. What's the immediate management? What do we do first?
First step, always, is vigorous bimanual uterine massage. 1 hand on the abdomen, 1 hand in the vagina, physically squeezing the uterus to try and stimulate contraction.
Okay, massage first.
Right. Also, make sure her bladder is empty. A full bladder can physically impede uterine contraction, so catheterize if needed.
Big point.
Then, high-dose intravenous oxytocin is the first-line medication. If that's not working, you move to other uterotonics. Things like misoprostol, Tranexamic acid, which helps stabilize clots, carboprest.
Hmm.
But remember, carboprest is contraindicated in asthma patients, and methylorgonavine, which is contraindicated in patients with hypertension.
Got the contraindications. Okay. What if meds aren't enough?
If medications and massage fail, the next step is often an intrauterine balloon tamponade, physically inflating a balloon inside the uterus to put pressure on the bleeding sites.
Okay.
And if bleeding still continues, you're looking at more invasive options like uterine artery embolization or ultimately surgery, potentially even a hysterectomy as a life-saving measure.
Wow. Okay, a clear escalation path.
Yeah.
Now, just defining postpartum hemorrhage, or PPH generally, what's the blood loss cutoff?
Right. The standard definition is blood loss greater than 500 milliliters after a vaginal delivery or greater than 1,000 milliliters after a cesarean delivery, although sometimes clinical signs of instability matter more than the exact number.
Right. And beyond uterine atony, what are other key risk factors for PPH in general?
A lot of the risk factors overlap with atony. So again, prolonged or induced labor, choriomamnitis, multiple gestation, polyhydramnios, grand multiparity, operative vaginal delivery, basically anything that makes the uterus work harder or get stretched out more.
And what are the other main causes of PPH besides atony? The 4 T's sometimes.
Exactly. The 4 T's are a good mnemonic. Tone, that's atony, the most common.
Yeah.
Trauma, lacerations of the cervix, vagina, perineum, or even uterine rupture. Tissue, retained placental fragments or membranes or placenta accreta. And thrombin, coagulopathy, either pre-existing or acquired, like DIC.
Tone, trauma, tissue, thrombin.
Got it. So when faced with a PPH, what's the initial management protocol, step by step?
Okay, it's rapid assessment in action. Check vitals, assess hemodynamic stability, call for help, start vigorous bimanual uterine massage immediately, secure 5V access, give high-dose oxytocin, start 4V fluids, give oxygen.
Okay, the basics first. Right. Then, if bleeding continues, quickly work through the other uterotonics we discussed. Consider the balloon tamponade. Systematically rule out the other causes, inspect for lacerations, check for retained placenta, consider coagulopathy. Escalate as needed to embolization or surgery.
It can be hard to judge blood loss visually. Your notes give some rough guides for peripads. Can you share those?
Yeah, these are just approximations, but can be helpful. Scant is usually less than a 1-inch stain, light less than 4 inches, moderate less than 6 inches, and heavy bleeding is generally defined as saturating a peripad within 1 hour.
Okay, helpful ballpark figures. Let's switch to a less common but very serious emergency. Amniotic fluid embolism. Here's the vignette. Advanced maternal age, multiple prior pregnancies. During labor, she suddenly develops cardiogenic shock, severe respiratory distress, and DIC. What should leap to mind?
That rapid onset triad cardiovascular collapse, respiratory failure, and DIC during or right after labor is highly suggestive of amniotic fluid embolism, or AFE. Risk factors include things like advanced maternal age, having had 5 or more pregnancies, Gravida 05, C-section or instrumental delivery, placenta previa or abruption, and preeclampsia. But it can happen without clear risk factors, too.
What's the treatment approach for suspected AFE?
Unfortunately, there's no specific cure. Management is intensely supportive, focusing on the life threats, aggressive respiratory support, often intubation and mechanical ventilation, hemodynamic support with fluids and vasopressors, and managing the DIC, which often requires transfusions of blood products, packed red cells, platelets, FFP, cryoprecipitate. It's about supporting the patient through the crisis.
Very challenging. Okay, let's shift focus to fetal heart rate monitoring. Fetal tachycardia baseline above 160. What are common causes?
The most common cause is probably maternal fever, often from choriamnionitis.
Fine.
Other causes include certain maternal medications like beta agonists, example terbutaline, fetal hyperthyroidism, rare, and fetal tachyarrhythmias. Sometimes hypoxia can initially cause tachycardia too.
And the opposite, fetal bradycardia baseline below 110. What might cause that?
Fetal bradycardia can be caused by maternal hypothermia, certain medications like beta blockers, fetal hypothyroidism, also rare, or congenital fetal heart block.
Heart block.
Yeah, sometimes associated with maternal autoimmune antibodies like anti-Ro SSA and anti-Laric SSB antibodies, seen in conditions like lupus or Sjogren's, can also be caused by acute severe hypoxia like uterine rupture or cord prolapse.
Okay, variability is another key feature. Can you define the different levels, absent, minimal, moderate, marked, and what they mean?
Sure. Variability refers to the fluctuations in the baseline fetal heart rate, the sort of jaggedness of the line.
Right.
Absent variability means there are no detectable fluctuations. Minimal variability is when the amplitude is detectable, but it's 5 beats per minute or less. Moderate variability, which is considered normal and reassuring, is an amplitude range of 6 to 25 beats per minute. And marked variability is when the amplitude is greater than 25 beats per minute.
And what can cause absent or minimal variability? Should we always be worried?
It can be worrying, but doesn't always mean disaster. Common causes include medications given to the mother, like opioids or magnesium sulfate, which can depress the fetal CNS.
Okay.
Fetal sleep cycles are another very common cause, usually resolves within about 40 minutes. Prematurity can also lead to lower variability because the nervous system isn't fully mature.
Right.
But persistent, absent, or minimal variability, especially with other non-reassuring signs like decelerations, is concerning for fetal hypoxia or acidemia.
Okay. Now let's break down the FHR tracing categories. Category I, what defines this reassuring pattern and what's the management?
Category A is the gold standard, strongly predictive of normal fetal acid-base status. You need a baseline rate between 110 and 160 BPM. Moderate variability, no late or variable decelerations.
Okay.
Early decelerations and accelerations may be present or absent. That's fine. Management for category A is just routine monitoring, expectant management, no specific intervention needed.
And category 2, what does that mean?
Category 2 is basically everything else that doesn't fit into Category 1 or Category 3. It's indeterminate.
Indeterminate.
Right. It means the tracing isn't clearly reassuring, but it's also not definitively abnormal or predictive of acidosis. These tracings need continued surveillance, evaluation of the whole clinical picture, and maybe some interventions to see if they improve.
And category 3, these are the concerning ones.
Yes, Category 3 tracings are considered abnormal and are associated with an increased risk of abnormal fetal acid-base status. Prompt evaluation and efforts to resolve the pattern are required.
What specific patterns put a tracing into category 3?
Okay, it's any of these. Absent baseline variability plus either recurrent late decelerations or recurrent variable decelerations. Or absent baseline variability plus bradycardia. Or a sinusoidal pattern. Any of those land you in Category 3.
Got it. Let's dig into the decelerations. Early decelerations, what causes them, and are they bad?
Early decelerations are gradual decreases in the FHR that mirror the contraction. The lowest point, the nadir, lines up with the peak of the contraction.
Okay, mirror image.
Exactly. They're caused by fetal head compression during the contraction, which causes a vagal response. They are considered benign, physiological, and don't require intervention.
Okay. How about late decelerations? How do they look different and what do they signify?
Late decelerations are also gradual decreases, but the key difference is their timing. The nadir occurs after the peak of the contraction.
After the peak.
Right. This timing lag indicates uteroplacental insufficiency. The placenta isn't delivering enough oxygen to meet the fetus's needs during the stress of a contraction. It's a sign of potential fetal compromise.
What kind of conditions cause that insufficiency?
Things like maternal hypotension, uterine tachysystole, placental abruption, chronic hypertension, post-term pregnancy, fetal growth restriction, anything that impairs oxygen transfer across the placenta.
Okay. And if that insufficiency becomes chronic?
Chronic uteroplacental insufficiency can lead to fetal growth restriction, reduced fetal activity, and eventually oligohydramnios because the fetus shunts blood away from the kidneys, reducing urine output.
Got it. Now, variable decelerations, they look different, right? More abrupt.
Yes. Variable decelerations are abrupt drops in the FHR, often V-shaped or U-shaped. Their onset, depth, and duration can vary, and they don't have a consistent relationship with contractions like earlies or lates do.
And the cause?
The most common cause by far is umbilical cord compression.
Cord compression. Okay. Are they always bad?
Not necessarily. If they are intermittent, meaning they occur with less than 50% of contractions and aren't too deep or prolonged, the fetus often tolerates them well.
Okay.
But if they become recurrent, occurring with 50% or more of contractions or are deep and prolonged, they can lead to fetal hypoxia and acidosis.
How do we manage concerning variable decelerations?
Initial steps are usually maternal repositioning, try left lateral, right lateral, even hands and knees to try and shift the fetus off the cord. Sometimes amnioinfusion, putting sterile fluid back into the uterus, can help cushion the cord, but that's contraindicated if there's been prior uterine surgery. If variables become severe and lead to a Category 3 tracing, delivery might be necessary, often by C-section.
You mentioned the sinusoidal pattern earlier as Category 3. What does that look like and what's the worry?
A sinusoidal pattern is very distinct. It's a smooth, sine wave-like undulation of the baseline FHR. It has a relatively fixed frequency, usually 3 to 5 cycles per minute, and amplitude, often 515 BPM. There's usually absent variability otherwise.
Okay, smooth wave.
Right. It's a very ominous pattern, category 3rd, often associated with severe fetal anemia. For example, from a ruptured vasa previa leading to acute fetal blood loss, or severe Rh isoimmunization. It requires urgent intervention, usually immediate C-section.
What about tracings in preterm babies? Do they look different?
Yes, they often do, especially before about 28 weeks. Preterm fetuses tend to have a higher baseline heart rate, sometimes above 160. Their variability is often lower, maybe in the minimal range, and their accelerations might be smaller in amplitude, maybe only 10 beats high instead of 15, and shorter duration.
Why is that?
It's primarily due to the immaturity of the fetal autonomic nervous system, particularly the sympathetic system, which isn't fully developed yet.
Okay, so if we encounter a Category 3 tracing, what's the immediate general management strategy?
Okay, category 3 needs action. First, try intrauterine resuscitation measures. Maternal repositioning, usually left lateral. Supplemental oxygen via non-rebreather mask. Increase IV fluids. And importantly, stop any uterotonics like oxytocin if they're running.
Try to improve oxygenation.
Exactly. If these measures don't quickly improve, the tracing and delivery isn't imminent, you need to proceed to delivery, usually an immediate cesarean section. If the patient is fully dilated and delivery is feasible, an operative vaginal delivery might be an option.
Your notes include an example tracing of fetal tachycardia. What are the key features?
Right. So in that example, you'd see the baseline FHR is consistently above 160 BPM, maybe around 180 in the example shown. You'd also assess variability. Maybe it's moderate look for accelerations, which might be present, and check for decelerations, which would ideally be absent, and note the contraction frequency.
Okay, let's briefly mention fetal stations. How do they relate to labor progress?
Fetal station describes how far the baby's presenting part, usually the head, has descended into the mother's pelvis. It's measured in centimeters relative to the ischial spines, which are bony landmarks in the pelvis.
Okay.
Zero station means the presenting part is right at the level of the spines. Negative numbers, like -1, -2, -3, mean the baby is still above the spines. Positive numbers, +1, +2, +3, mean the baby has passed the spines and is moving down towards the outlet. Engagement usually means the head is at zero station or below.
Got it. Now, uterine contraction abnormalities. Let's start with tachycystal. Definition and why is it a problem?
Tachysystole is defined as more than 5 uterine contractions in a 10-minute period, averaged over 30 minutes.
More than 5 in 10.
Okay. The concern is that contractions, especially frequent ones, reduce blood flow to the placenta. If they're too close together, the fetus doesn't get enough time to recover oxygen between them. This can lead to fetal distress, often showing up as late decelerations on the FHR tracing.
How do we manage tachycystal if we see it?
First, try simple things like putting the mother in a lateral position to improve placental perfusion. If she's receiving oxytocin, decrease or stop the infusion. If it persists and the FHR is concerning, sometimes a tocolytic medication like terbutaline might be given to slow down the contractions.
What about tetanic contractions? What are those?
A tetanic contraction is one that lasts for a really long time, typically defined as longer than 2 minutes.
Wow, 2 minutes.
Yeah, like tachysystole, a prolonged contraction can severely compromise fetal oxygenation because blood flow is restricted for so long. Management, again, often involves giving a tocolytic like terbutaline to help the uterus relax.
Okay. We also have Montevideo units, MVUs. What do they measure and what's considered adequate?
Montevideo units quantify the intensity of uterine contractions over a 10-minute period. You can only calculate them if you have an intrauterine pressure catheter, or IUPC, in place.
Need an IUPC.
Right. You measure the peak pressure of each contraction in mmHg, subtract the baseline uterine tone, and then sum up those intensity values for all contractions in a 10-minute window. Labor progression is generally considered adequate if the MVUs are consistently 200, 250 or more. It helps objectively assess if contractions are strong enough.
Okay, good objective measure. Let's quickly summarize the 3 main decelerations again. Early, variable, late. Key features and cause.
Sure. Early decels. Gradual onset. Mirror the contraction. Nadir at contraction peak. Cause. Head compression. Benign.
Okay.
Variable decels. Abrupt onset, shape, and timing vary. Mines. Cord compression. Can be okay if intermittent. Concerning if recurrent severe.
Got it.
Late decels. Gradual onset. Nadir after contraction peak. Cause. Uteroplacental insufficiency. Concerning.
Perfect recap. Now, twin pregnancies. What are the different ways we classify them based on placentas and sacs?
We classify them based on chorionicity, number of placentas,
Mhm.
and amnionicity, number of amniotic sacs.
Okay.
You can have monochorionic, monoamniotic, or monomono, or momo. They share one placenta A and D, one amniotic sac, very high risk.
One sac, one placenta.
Right. Then monochorionic diamniotic, monodia, or MODI. They share one placenta but have two separate amniotic sacs. You see a thin dividing membrane, the T sign on ultrasound.
T sign. Okay.
And finally, dichorionic, diamniotic, D-di, they have two separate placentas, which might be fused, and two separate sacs. You often see a thicker membrane, the lambda sign or twin peak sign on ultrasound.
Lambda sign for DD. Got it. Are there increased risks for the mother carrying twins?
Oh, definitely. Mothers carrying twins have higher rates of hyperemesis gravidarum, that's severe nausea vomiting, preeclampsia, gestational diabetes, iron deficiency anemia, postpartum hemorrhage, the list goes on. It's just physiologically more demanding.
And for the babies, what are their added risks?
The fetuses also face more challenges. Higher rates of congenital anomalies, fetal growth restriction, much higher risk of preterm delivery, and malpresentation like breech.
Okay.
Plus, monochorionic twins have the specific risk of twin-twin transfusion syndrome, TTTS. And those mono-mono twins have unique risks like cord entanglement and conjoined twins.
Let's focus on those monochorionic, monoamniotic twins. Why are they considered particularly high risk?
They are the highest risk type because of that shared environment. Sharing one placenta puts them at risk for TTTS, just like monodi twins. But sharing the same sac means their umbilical cords can easily become tangled or knotted, which can cut off blood flow and lead to fetal distress or even demise.
Cord entanglement. Wow.
Exactly. Plus, like all twins, they have a very high risk of preterm birth due to uterine overdistension and associated maternal complications.
So how are these mono pregnancies usually managed given these risks?
Management is very intensive, often involves inpatient admission starting around 28 weeks for frequent fetal monitoring, like daily NSTs and regular ultrasounds.
Inpatient from 28 weeks.
Often, yes. Antenatal corticosteroids are given to promote fetal lung maturity, and delivery is almost always by planned cesarean section, typically between 32 and 34 weeks, to balance the risks of prematurity against the increasing risks of cord accident or stillbirth if they stay in longer.
Okay, C-section at 32, 34 weeks. Let's revisit the T sign and lambda sign.
Yeah.
What exactly are we seeing on ultrasound and why is it so important?
These signs help us determine chorionicity early, which is vital for risk assessment. The T sign you see in monody twins is where the thin dividing membrane between the two sacs inserts perpendicularly into the single shared placenta, forming a T shape at the junction.
Okay, thin membrane T shape.
Right. The lambda sign, or twin peak sign, is seen in Di twins. It's a triangular projection of placental tissue extending up into the base of the dividing membrane, because you have two chorions fusing there. It looks like the Greek letter lambda.
Thicker base, lambda shape.
Exactly. Finding that lambda sign early is reassuring because it means they're dichorionic, lower risk for things like TTTS.
Okay, let's talk about twin-twin transfusion syndrome. What's the basic problem and what happens to the two twins involved?
TTTS is a serious complication specific to monochorionic twins, happening in about 10–15% of them. It's caused by unbalanced blood flow through abnormal connections, called anastomosis, within the shared placenta.
Okay, shared plumbing problem.
Pretty much. Blood flows preferentially from one twin, the donor, to the other, the recipient.
What happens to the donor twin?
The donor twin effectively gives away too much blood. They become anemic, their kidneys don't get enough blood flow, so they produce less urine, leading to oligohydramnios, low fluid. They can develop growth restriction and even low output heart failure.
And the recipient gets too much.
Exactly. The recipient gets overloaded with blood, they become polycythemic, too many red blood cells, their kidneys produce excess urine, leading to polyhydramnios, too much fluid. Their heart gets overworked trying to pump all that extra volume, leading to cardiomegaly and potentially high output heart failure and hydrops fatalis, generalized edema.
How is TTTS treated?
Management depends on the severity, often classified by Quintero stages. For mild cases, sometimes close observation with serial ultrasounds is enough. For moderate to severe TTTS, the standard treatment is fetoscopic laser ablation.
Laser ablation.
Yeah, a minimally invasive surgery where a laser is used to coagulate and seal off those abnormal vascular connections on the surface of the placenta, aiming to stop the unbalanced transfusion.
Okay, let's shift to hyperemesis gravidarum. How is this different from just regular morning sickness?
Hyperemesis gravidarum is way beyond typical morning sickness. It's severe, persistent nausea and vomiting that leads to significant problems like dehydration, electrolyte imbalances, ketosis, and weight loss, usually more than 5% of pre-pregnancy body weight.
More than 5% weight loss.
Okay.
What's the underlying physiology thought to be?
It's strongly linked to the high levels of beta-HCG in early pregnancy. HCG is thought to directly stimulate nausea centers. Progesterone also plays a role, likely by relaxing the lower esophageal sphincter and slowing gastric emptying, making vomiting more likely.
What kind of patient might be at higher risk for developing hyperemesis?
Risk factors include having had hyperemesis in a prior pregnancy, that's a big one. Carrying multiples, like twins or triplets, because HCG levels are higher. Having a hydatidiform mole, again, very high HCG. Also, maybe a history of motion sickness or migraines seems to be linked.
How does hyperemesis typically present? What are the signs of severity we look for?
Presentation is that intractable nausea and vomiting. Signs of severity relate to the consequences. Clinical dehydration, dry mucous membranes, poor skin turgor, tachycardia, delayed cap refill, orthostatic hypotension, evidence of malnutrition, like that significant weight loss, and ketonuria on urine dipstick is a key finding, showing fat breakdown due to starvation.
What about lab findings?
Labs often show electrolyte abnormalities like hypokalemia, low potassium, and hypochloremic metabolic alkalosis from losing stomach acid. Liver enzymes, AST and ALT, can sometimes be elevated. And interestingly, some women can develop transient hyperthyroidism because the high HCG weakly stimulates the thyroid.
Interesting. What's the standard management approach?
Management often requires hospitalization, especially initially. The cornerstones are IV fluids for rehydration and electrolyte correction, antiemetic medications, often using multiple agents from different classes, and nutritional support if they can't keep anything down. Sometimes vitamin supplementation, especially thiamine, is crucial.
Why thiamine specifically? You mentioned Wernicke encephalopathy as a potential complication. Tell us about that.
Yes, Wernicke encephalopathy is a serious neurological emergency caused by thiamine, or vitamin B1, deficiency. It can happen in severe, prolonged hyperemesis due to malnutrition.
Quick.
The classic triad is confusion or altered mental status, oculomotor dysfunction, things like nystagmus or gaze palsies and gait ataxia, difficulty walking. You might also see absent ankle reflexes.
How do we manage suspected Wernicke's?
It's critical to give thiamine before administering any glucose-containing IV fluids, because glucose can actually precipitate or worsen Wernicke's in someone who is thiamine deficient. So give thiamine first, then fluids, antiemetics, etc. It also increases the risk of miscarriage, and you need to distinguish it from acute fatty liver of pregnancy, which usually happens later in the third trimester and presents more with jaundice.
Thiamine before glucose.
Yeah.
Got it. Let's talk thyroid changes in normal pregnancy. What happens?
Okay, so estrogen levels rise significantly in pregnancy. This causes the liver to produce more thyroxine-binding globulin, or TBG, the main protein that carries thyroid hormone in the blood.
More TBG. Okay.
Right. So because there's more binding protein, the total T4 and T3 levels in the blood increase. However, the amount of free active hormone-free T4 and free T3 generally stays within the normal range, or maybe mildly elevated early on.
So total goes up, free stays mostly normal.
Exactly. And TSH, thyroid stimulating hormone, is often slightly suppressed in the first trimester. This is partly because beta-HCG has some structural similarity to TSH and can weakly stimulate the thyroid gland itself. Overall, the woman remains euthyroid or has maybe subclinical hyperthyroidism.
What does this mean for women who already have hypothyroidism and are on thyroid replacement?
They almost always need to increase their levothyroxine dose during pregnancy, often by about 30%, usually early in the first trimester. This is to compensate for that increased TBG and ensure enough free T4 gets to the fetus, which relies on maternal thyroid hormone early on. Frequent monitoring of TSH is needed.
Okay, dose increase needed. What about the baby? Can newborns get thyrotoxicosis?
Yes. Neonatal thyrotoxicosis can happen if the mother has Graves' disease, which is caused by TSH receptor-stimulating antibodies.
Okay.
These maternal antibodies can cross the placenta and stimulate the baby's thyroid gland, causing the baby to become hyperthyroid.
How would that baby present?
The baby might be irritable, tachycardic, fast heart rate, feed poorly, have poor weight gain, maybe warm, moist skin. Sometimes they're born preterm or small for gestational age. Diagnosis is confirmed by finding high levels of those stimulating antibodies in the mother. Treatment for the baby usually involves anti-thyroid meds like methimazole and maybe a beta blocker for symptoms. It's usually temporary, resolving in a few months as the maternal antibodies clear.
Got it. We also have Sheehan syndrome in the nose. What is that?
Sheehan syndrome is postpartum pituitary necrosis. It's caused by severe hypertension or shock, usually due to massive obstetric hemorrhage during or after delivery.
Okay, pituitary damage from blood loss.
Right. The pituitary gland actually enlarges during pregnancy and becomes more vulnerable to ischemia. If it gets damaged, it can lead to deficiencies in various pituitary hormones.
What are the typical symptoms or signs?
Symptoms depend on which hormones are deficient. Failure to lactate postpartum due to low prolactin is often the first sign. Others include amenorrhea, no periods, hot flashes, vaginal atrophy due to low FSH/LH, fatigue, bradycardia from low TSH, anorexia, weight loss, hypertension from low ACTH, maybe decreased lean body mass from low growth hormone. It can be a gradual onset.
Okay, multifaceted presentation. Let's talk about migraines in pregnancy. Do they get better or worse?
It varies, but often women who suffer from migraines actually experience improvement during pregnancy.
Oh, interesting. Why?
It's thought to be related to the more stable high levels of estrogen and progesterone, avoiding the cyclical hormonal fluctuations that can trigger migraines in non-pregnant women. However, some women do find their migraines worsen, maybe due to other factors.
What are the safe treatment options if migraines do occur during pregnancy?
Safety is paramount. For acute treatment, acetaminophen is first line. If that's not enough, options might include acetaminophen with codeine, certain antiemetics, maybe caffeine-metalbutol combinations. Oxycodone could be used for severe refractory cases.
What should be avoided?
Generally, ergotamines and triptans are avoided due to concerns about vasoconstriction and potential effects on uterine contractions, possibly leading to preterm labor or fetal growth restriction. NSAIDs are usually avoided in the first trimester due to a possible link with miscarriage, and definitely avoided in the third trimester because they can cause premature closure of the ductus arteriosus and fetal kidney problems. They might be used cautiously in the second trimester.
What about preventative meds?
For prevention, beta blockers like propranolol are often considered first line. Calcium channel blockers are another option. Prolonged beta blocker use might carry a small risk of FGR, so you'd monitor closely.
Okay. Let's move to types of abortion or early pregnancy loss. Can you quickly define threatened, inevitable, incomplete, complete, and missed abortions based on bleeding, cervix status, and ultrasound?
Sure. Threatened abortion, vaginal bleeding, but the cervix is closed, and ultrasound shows a viable intrauterine pregnancy, IUP, fetal heart activity is present.
Okay. Bleeding but viable, closed cervix.
Inevitable abortion, bleeding, cramping, and the cervix is open or dilated. Ultrasound usually shows a non-viable pregnancy, maybe low in the uterus or in the process of expulsion.
Bleeding, open cervix.
Incomplete abortion, bleeding, open cervix. But some products of conception, POC, have passed and some remain inside the uterus on ultrasound.
Some tissue passed, some remains, open cervix.
Complete abortion. All products of conception have been expelled. Bleeding and cramping have usually subsided, the cervix is typically closed, and ultrasound shows an empty uterus. Beta HCG is still positive initially, but declining.
All tissue passed, closed cervix, empty uterus.
And missed abortion. Fetal demise occurred, 20 once, but the POC have not been expelled. The cervix is closed, there may be no bleeding, and the woman might be asymptomatic or notice loss of pregnancy symptoms. Ultrasound confirms no fetal cardiac activity or an empty sac.
Fetal demise, but tissue retained, closed cervix. Got it.
Exactly.
Let's focus on spontaneous abortion, miscarriage. What are key risk factors?
Major risk factors include advanced maternal age, a history of prior miscarriages, and substance use, smoking, alcohol, cocaine. Chromosomal abnormalities in the fetus are actually the most common cause overall, especially in the first trimester.
Okay. In the case of an inevitable abortion, what are the management options?
If the patient is stable, options are expectant management, waiting for it to pass naturally, medical management with misoprostol to induce expulsion, or surgical management with suction curettage, DNC.
What if the patient is unstable? Heavy bleeding.
If she's hemodynamically unstable or bleeding very heavily, then surgical evacuation with a DNC is usually the preferred and quickest approach. Oxytocin isn't really effective for inducing expulsion this early in pregnancy.
What other management points are important?
Remember Rho-D immune globulin ROGAM if the mother is Rh negative. Sending the tissue for pathology can sometimes be helpful. And counseling about potential complications like hemorrhage, retained tissue, infection, septic abortion, uterine perforation, or later on, Asherman's syndrome, intrauterine adhesions.
Okay. For a missed abortion, what are the typical features again?
Missed abortion is that fetal demise before 20 weeks where everything is still retained. So no bleeding usually, closed cervix. Woman might feel fine or notice her pregnancy symptoms faded. Ultrasound confirms no cardiac activity or an empty sac. Beta HCG levels might be plateaued or falling. Management is usually D&C or medical management with misoprostol.
And complete abortion, how does that typically present?
Usually the woman reports passing tissue, often accompanied by significant cramping and heavy bleeding with clots. After everything passes, the pain and bleeding typically decrease significantly. The cervix may be closed on exam, and ultrasound shows an empty uterus. Beta HCG is still positive for a while. Again, substance use can be a risk factor.
Threatened abortion characteristics.
Bleeding before 20 weeks, closed cervix, and a confirmed viable intrauterine pregnancy on ultrasound. You might see a subchorionic hematoma as the source of bleeding.
Septic abortion risk factors and presentation.
Septic abortion is an infection involving retained POC. Risks include unsafe or non-sterile elective abortions, or sometimes just an incomplete or missed abortion that becomes infected.
Okay.
Presentation is typical for infection. Fever, chills, lower abdominal pain, maybe foul-smelling, purulent vaginal discharge. On exam, the uterus is often very tender, maybe feels boggy, and the cervix is usually open. Ultrasound might show retained POC, maybe gas in the uterus, thickened endometrial stripe.
How do we manage septic abortion? What's the priority?
It's an emergency.
Right.
Priority is stabilization with IV fluids, prompt administration of broad-spectrum IV antibiotics to cover likely polymicrobial infection, like clindamycin and gentamicin. Then, once stable, surgical evacuation of the uterus suction curettage is necessary to remove the infected tissue, the source of the infection.
Okay, fluids, antibiotics, DNC.
Right. Misoprostol isn't usually used here because it's too slow. In rare severe cases, like a pelvic abscess, or if she doesn't improve, hysterectomy might be needed.
Your notes show a subchorionic hematoma image. Just briefly, what is that?
It's just a collection of blood between the chorion, the membrane around the sac, and the uterine wall. It's a common cause of first trimester bleeding, often seen with threatened abortions. Many resolve on their own.
Okay, uterine rupture. Which patients are most at risk, and what are the signs?
The biggest risk factor is a prior uterine scar, especially from a classical C-section or sometimes a myomectomy that went deep into the uterine wall.
Prior scar, okay.
Signs can be sudden, intense abdominal pain, often right at the scar site, though it might become diffuse. Vaginal bleeding can occur, signs of shock. Fetal distress is common bradycardia, late decels. A classic, though not always present, sign is loss of fetal station. The baby's head moves up in the pelvis.
Loss of station.
Right. You might even feel fetal parts more easily through the abdomen. Contractions might decrease or stop, sometimes called the staircase sign as amplitude diminishes. It's a surgical emergency.
Sure.
Immediate laparotomy for delivery of the baby and repair of the uterus if possible. Sometimes hysterectomy is necessary if the rupture is extensive or repair isn't feasible.
Okay. Intrauterine fetal demise, IUFD, definition and potential causes.
IUFD is fetal death at or after 20 weeks gestation. Causes can be maternal, like uncontrolled diabetes, hypertension, antiphospholipid syndrome, severe infection, fetal-maternal hemorrhage, fetal chromosomal abnormalities, structural defects, infection, or placental abruption, thrombosis, infection, cord accident.
Okay.
Risk factors include things like fetal growth restriction, prior IUFD, smoking, obesity, diabetes, hypertension, advanced maternal age, null parity. But frustratingly, often no clear cause is found even after evaluation.
How might it present and how is it confirmed?
The most common presentation is the mother reporting decreased or absent fetal movement. Diagnosis is confirmed by ultrasound showing absence of fetal cardiac activity. Doppler alone isn't reliable enough for confirmation.
Management approach after diagnosis.
Management involves discussing delivery options. Induction of labor is usually offered. Timing can be somewhat flexible unless there's a maternal reason for urgency. But prolonged retention, weeks, increases risk of maternal coagulopathy.
Okay.
Method depends on gestational age and prior history, maybe D&E in second trimester. Vaginal induction preferred later unless contraindicated, like prior classical C-section.
No.
Post-delivery evaluation is key. Fetal autopsy, placental examination, karyotype, Gleichauer-Betke test for fetal-maternal hemorrhage, maternal testing for things like APL antibodies, thrombophilias, diabetes.
You mentioned antiphospholipid antibody syndrome, diagnostic criteria.
Right. APS requires at least one clinical criterion, either a vascular thrombosis, arterial or venous clot, or specific pregnancy morbidity, like recurrent early losses, one late loss, or preterm delivery due to preeclampsia placental insufficiency. PLUS, at least one laboratory criterion.
Lab criteria.
Positive test on 2 occasions at least 12 weeks apart for lupus anticoagulant, or anticardiolipin antibodies, IgG or IgM, or anti-beta 2 glycoprotein I antibodies, IgG or IgM.
And management during pregnancy.
Usually involves anticoagulation, typically with heparin or low molecular weight heparin, often combined with low-dose aspirin, to reduce thrombosis risk and improve pregnancy outcomes.
Okay, quick mention of SLE, lupus, common manifestation.
Oh, SLE is multisystem. Can see things like pleuritis, pericardial effusion, skin rashes like the Meller rash or discoid lupus, levator reticularis, arthritis, seizures, psychosis, cognitive issues, increased risk of thrombosis.
And lupus nephritis in pregnancy, how might that look?
It can mimic preeclampsia with edema and hypertension, but you'll often have other SLE features like joint pain, malar rash. Your analysis is key look for hematuria, proteinuria, and especially red blood cell casts, which point towards nephritis. Labs might show low complement levels, C3, C4, and high anti-dsDNA titers.
Risks in pregnancy with lupus nephritis.
Higher risk of flares, especially if disease was active before pregnancy or if hydroxychloroquine was stopped. Increased obstetric risks like preterm birth, C-section preeclampsia, FGR, IUFD. Diagnosis might need a renal biopsy.
Okay, preterm labor, definition and major risk factors.
Preterm labor is regular, painful uterine contractions causing cervical change, dilation, and order effacement, occurring before 37 completed weeks of gestation.
Before 37 weeks. Risks.
The single biggest risk factor is a history of a prior preterm birth. Others include having a short cervix on transvaginal ultrasound, like 802 centimeters with no history, or 8.5 centimeters with history, prior cervical surgery, cone biopsy, AEP, multiple gestation, uterine anomalies, infections, UTI, bacterial vaginosis, periodontal disease, smoking, substance use, low socioeconomic status, advanced maternal age, iron deficiency anemia.
How do we measure that cervical length?
Transvaginal ultrasound measurement in the mid-trimester is the gold standard for assessing cervical length and risk.
Okay. Management strategies for preterm labor.
Depends on gestational age. Tocolytics might be used to temporarily stop contractions, aiming to delay delivery long enough for corticosteroids to work. Common tocolytics include indomethacin, usually 32 mins due to PDA, closure oligohydramnios risk, nifedipine, a calcium channel blocker, tributylene, a beta agonist, and magnesium sulfate.
Corticosteroids.
Yes, betamethasone is given typically between maybe 23 or 24 weeks up to 34 or even 36 plus 6 weeks, depending on guidelines, to accelerate fetal lung maturity.
Other key interventions.
Yeah. Penicillin or other antibiotics if the mother is GBS positive or status unknown to prevent neonatal GBS sepsis. And magnesium sulfate is given for fetal neuroprotection if delivery is anticipated before 32 weeks.
Okay. External cephalic version, ECV. What is it and when is it absolutely contraindicated?
ECV is a procedure where the provider tries to manually turn a breech or transverse baby to a head-down position by manipulating the fetus through the mother's abdomen, usually done around 37 weeks.
Okay, flipping the baby. Contraindications.
Absolute contraindications include situations where vaginal delivery is already contraindicated, like placenta previa, or if there's been a prior classical C-section or extensive uterine surgery like myomectomy due to rupture risk. Also active labor, ruptured membranes usually.
Any relative contraindications or complications?
Relative ones might include oligohydramnios, suspected FGR, prematurity. It's generally not done during active labor. Complications are rare, but can include placental abruption, cord accident, or fetal distress leading to emergency C-section.
Okay, abruptio placentae. Risk factors and classic presentation.
Risk factors include maternal hypertension, chronic or preeclampsia, trauma like a car accident or fall, smoking, cocaine use, prior abruption, rapid decompression of uterus like after rupture of membranes with polyhydramnios.
How does it typically present?
Classic presentation is sudden onset of vaginal bleeding, though bleeding can be concealed behind the placenta, constant abdominal or back pain, uterine tenderness, and often a firm or rigid uterus. You might see frequent low-amplitude contractions, uterine irritability on the monitor, and fetal heart rate abnormalities like decelerations or loss of variability are common due to fetal hypoxia.
Management.
Depends on severity and fetal status. Requires immediate evaluation, IV access, fluids, continuous fetal monitoring. Often delivery is necessary, especially if there's significant bleeding or fetal distress. Usually by C-section if urgent. Maternal complications like DIC and hypovolemic shock are major concerns.
How do we differentiate abruption from uterine rupture or vasoprevia?
Uterine rupture often has history of prior scar, maybe loss of fetal station, cessation of contractions. Vasoprevia typically presents with painless bleeding immediately upon rupture of membranes, often with acute fetal bradycardia or sinusoidal pattern. Abruption usually has pain and uterine tenderness.
Okay. Vasoprevia. What is it? Risk factors.
Vasoprevia is when unprotected fetal blood vessels run across the internal cervical os within the membranes. Huge risk of rupture when membranes break or during labor.
Unprotected vessels over the cervix. Risks.
Risk factors include placenta previa or a low-lying placenta earlier in pregnancy, pregnancies from IVF, multiple gestation, and presence of a sexcentriate placental lobe, an accessory lobe connected by vessels.
Presentation and management.
Presentation is often that sudden onset of painless vaginal bleeding coinciding with rupture of membranes or contractions, followed quickly by fetal heart rate abnormalities like bradycardia, variable D cells, or sinusoidal pattern, indicating rapid fetal blood loss, exsanguination. If diagnosed prenatally via ultrasound, often with color Doppler, management is planned C-section, usually around 34-35 weeks. If it presents acutely during labor, it's an emergency C-section.
Got it. Preeclampsia again, let's nail down the criteria.
New onset hypertension, HOPI 90 at or after 20 weeks gestation, plus either proteinuria, 300 mg 24-hour, PC ratio 0.3, or dipstick or 1+, or signs of end organ damage. Severe features.
Risk factors again.
High yield ones. Nulliparity, multiple gestation, age 18 or 35, pre-existing diabetes, chronic kidney disease, chronic hypertension, history of prior preeclampsia, autoimmune disease like SLE or APS, obesity. High-risk women might need baseline 24-hour urine,
Pathophysiology reminder.
abnormal placental development, a poor spiral artery remodeling, uteroplacental insufficiency, release of anti-angiogenic factors,
Right.
systemic endothelial dysfunction, hypertension, and end organ damage. Can also cause FGR.
What constitutes severe features?
Okay, severe features include BPO 160 systolic or Rohan diastolic, on 2 occasions 4 hairs apart. Platelets 100,000, liver enzymes 2x upper limit of normal OR, severe RQ epigastric pain, creatinine or 1.1 milli-GDL or doubling of baseline. Pulmonary edema, new onset headache unresponsive to meds or visual disturbances. Hyperreflexia clonus often present to
Maternal complications.
abruption, DIC, eclampsia, hepatic rupture or hematoma, pulmonary edema, stroke, posterior reversible encephalopathy syndrome, PRES, acute kidney injury, serious stuff.
Antihypertensives for acute severe BP.
5-E lepitalol, IV hydralazine, oral nifedipine are the usual go-tos. Avoid ACE inhibitors, ARBs. Methyl-dopa is more for chronic management.
How to prevent it in high-risk women.
Low-dose aspirin typically started around 12 weeks gestation for women with high-risk factors or multiple moderate risk factors.
Stroke risk and preeclampsia.
Yes, increased risk of both ischemic stroke due to hypercoagulability, endothelial dysfunction, vasospasm, and hemorrhagic stroke due to severe hypertension leading to vessel rupture. Need head CT if persistent neurosymptoms, severe headache, or seizure.
Special consideration. Preeclampsia patient with myasthenia gravis. Seizure prevention.
Magnesium sulfate is generally contraindicated in MG patients as it can precipitate a myasthenic crisis. An alternative anticonvulsant like valproic acid might be considered, although levetiracetam is perhaps more common now. Need neurology consult. Avoid certain other meds in MG too.
Eclampsia warning signs before the seizure.
Often preceded by symptoms of severe preeclampsia, severe persistent headache, visual changes, blurred vision, scotomata, epigastric or RUQ pain. But seizures can occur without warning signs too. Usually generalized tonic-clonic, followed by postictal state.
Management of eclampsia.
Immediate priorities. ABCs, prevent injury during seizure. Then magnesium sulfate IV loading dose, followed by maintenance infusion to prevent recurrence. Control severe hypertension. And then expedite delivery once mother is stabilized.
Pulmonary edema and preeclampsia pathophysiology recap.
Multifactorial. Increased systemic vascular resistance after load, increased capillary permeability due to endothelial damage, decreased plasma oncotic pressure, low albumin sometimes, and often impaired renal function leading to volume overload, fluid leaks into lungs.
Can preeclampsia occur after delivery?
Yes, postpartum preeclampsia can occur usually within the first week, but up to 6 weeks postpartum. Severe headache is a very common presenting symptom, needs prompt recognition and treatment similar to antepartum preeclampsia.
Okay, quick review of safe antihypertensives in pregnancy.
First line, labetalol, nifedipine, long-acting, hydralazine, especially acute, methyldopa, chronic,
Avoid.
ACE inhibitors, ARBs, direct renin inhibitors, nitroprusside, cyanide risk, spironolactone. Thiazides are sometimes used second line but can decrease plasma volume.
Antepartum fetal surveillance methods again.
Non-stress test, NST, biophysical profile, BPP includes NST plus 4 U.S. components. Fluid movement, tone, breathing. Contraction stress test, CST checks FHR response to contractions. Umbilical artery Doppler sonography assesses placental resistance.
Patient reports decreased fetal movement. What's the workup?
Start with an NST, allow maybe 40 months. If non-reactive, proceed to BPT or maybe CST if no contraindications.
BPP results interpretation.
Score 8, 10, 10 is generally reassuring. 6, 10 is equivocal, usually repeat in 24 H'ers. 0, 4, 10 is abnormal, suggests fetal compromise hypoxia, often warrants urgent delivery. Abnormal BPP often linked to placental dysfunction from things like HTN, diabetes, smoking, post-term.
Okay. Infertility definition.
Inability to conceive after 12 months of regular unprotected intercourse if woman 35 years old or after 6 months if woman 35 years old.
Fibroids. Leiomyomas. How might they present?
Can cause heavy menstrual bleeding, especially submucosal intramural, pelvic pressure or pain, urinary frequency, constipation, especially subserosal, can cause infertility or recurrent pregnancy loss. Exam might reveal an enlarged, irregular uterus, can cause size-date discrepancy in pregnancy,
Obstetric complications with fibroids.
increased risk of miscarriage, malpresentation, placental abruption, preterm labor, postpartum hemorrhage.
Management is symptomatic.
Depends on symptoms and desire for fertility. Medical options, hormones, GnRH agonists temporarily, surgical, myomectomy, removes fibroids, preserves uterus if fertility desired. Hysterectomy removes uterus if childbearing complete and symptoms severe. Hysteroscopic myomectomy for submucosal ones.
Types of fibroids recap.
Submucosal, project into cavity, intramural within the wall, subserosal on the outer surface, pedunculated on a stalk, either subserosal or submucosal.
Fibroid degeneration during pregnancy.
Rapid growth due to hormones can outstrip blood supply, infarction necrosis, pain, uterine tenderness, contractions, sometimes fever leukocytosis. Usually managed conservatively with pain control. NSAIDs, okay short-term and second try, avoid later.
Uterine sarcoma versus fibroid.
Sarcoma is rare, malignant. Fibroids are common, benign. Sarcoma risk factors, postmenopausal, tamoxifen use, pelvic radiation, presentation, often postmenopausal bleeding, rapidly enlarging uterus, pelvic pain. Diagnosis usually requires surgical pathology, much worse prognosis.
Asherman syndrome, Trotter-Sinecki. Cause.
Scarring adhesions inside uterine cavity, usually due to damage to endometrial basalis layer from instrumentation, most commonly DNC, especially after pregnancy, can also be from infection, endometritis.
Presentation of Asherman's.
Can cause secondary amenorrhea, no periods, or hypomenorrhea, very light periods, infertility, recurrent pregnancy loss, sometimes cyclic pelvic pain if outflow obstructed, negative progesterone withdrawal tests.
Diagnosis and treatment.
Diagnosis by hysteroscopy, direct visualization. Treatment is hysteroscopic lysis of adhesions, often followed by measures to prevent recurrence like IUD placement and estrogen therapy.
Intrahepatic cholestasis of pregnancy, ICP. Cause and presentation.
Impaired bile acid flow likely due to hormonal effects, estrogen, progesterone, buildup of bile acids in blood. Presents with intense pruritus itching, often worse on palm soles, usually without a primary rash. May have RUQ pain.
Labs and risks.
Key lab, elevated total serum bile acids, 10 millimole. Liver enzymes, often elevated too. Risks, increased risk of IUFD, especially if bile acids 100. Preterm delivery, meconium staining, neonatal respiratory distress.
Treatment.
Ursodeoxycholic acid, UDCA, is first line, improves bile flow and itching, may reduce risks. Delivery usually recommended around 37 Wentz or earlier if severe.
Gallstones in pregnancy.
More common due to estrogen, acholectoral secretion, and progesterone, agallbladder motility. Presentation. RUQ epigastric pain, often postprandial. Diagnosis via U.S. management, often conservative, but cholecystectomy may be needed if recurrent complicated.
Polymorphic eruption of pregnancy, PU-PPP.
Itchy rash starts in abdominal stue, stretch marks, spreads out centrifugally, typically spares face, palms, soles. Benign treatment. Topical steroids for itching resolves after delivery.
Fetal growth restriction, FGR. Definition types.
Estimated fetal weight 10th percentile for gestational age. Symmetric FGR, proportionally small head body, often early onset, think chromosomal issues or early infection. Asymmetric FGR, head sparing, abdomen smaller than head, often later onset, second, third try, usually due to uteroplacental insufficiency, like from HTN, smoking, poor nutrition.
Appearance of FGR baby.
Thin, loose skin, decreased fat, thin cord, wide fontanelles. May have meconium staining. Placenta often abnormal.
Management of FGR.
Close surveillance, weekly BPPs, serial growth ultrasounds, umbilical artery Dopplers. Address underlying cause if possible. Timing of delivery depends on severity, Doppler findings, gestational age.
Hypertension and asymmetric FGR link.
HTN, placental insufficiency. Fetus shunts blood to brain. Head growth relatively spared, abdominal growth restricted. Neonatal risks, polycythemia from chronic hypoxia, hypoglycemia, hypothermia, hypocalcemia.
Septic pelvic thrombophlebitis. When does it occur?
Postpartum complication, usually after C-section or delivery, complicated by infection, endometritis. Thrombosis, clot, forms in pelvic veins, ovarian, iliac, due to hypercoagulability, stasis, endothelial injury. Then clot gets infected.
Presentation and treatment.
Persistent postpartum fever, unresponsive to broad-spectrum antibiotics, often no localizing signs. Diagnosis of exclusion. Treatment, anticoagulation, heparin L MLWH, and continued broad-spectrum antibiotics.
Anemia definition in pregnancy.
Hemoglobin 11 GDL in first, third trimesters, 10.5 GDL in second trimester.
Thrombocytopenia differentials in pregnancy. Quick rundown.
Gestational, mild, late onset, isolated, benign. Preeclampsia LLP, moderate severe with HTN, LFTSCR. ITP, isolated, can be severe, autoimmune. TTP, rare, severe with neurofeverenal, RAHA. DIC, mod severe with bleeding, clotting, abnormal coags.
Gestational thrombocytopenia management.
Benign, mild, usually 100K, 150K, late pregnancy. Reassurance and observation, usually resolves postpartum. No specific treatment needed.
Heparin-induced thrombocytopenia, HIT. When to suspect?
Suspect if on heparin 5 days, any platelets drop 50% or new thrombosis, arterial venous, or skin necrosis at injection site, or acute systemic reaction post-bolus. Diagnosis via serotonin release assay. Treatment. Estopiel heparin, start non-heparin anticoagulant, example, argatroban, fonaparinux.
Normal physiologic changes. Recap key systems.
CV, ACO, ASV, then AHR, ASVR, ABP, mid-preg, R plasma volume, ARBC mass, dilutional anemia. Renal. ARBF, AGFR, ABUNCR. Viral proteinuria, okay, 300 milligrams. HEVM, hypercoagulable factors, A protein S. Mild OWBC, palm, T12 volume, ARFRC, dyspnea common.
Coagulation changes.
Prothrombotic state. Our fibrinogen, factor 7, 8X, VWF. Protein S, protein C resistance increases. Increased risk of VTE.
Placenta previa, presentation and risks.
Painless, bright red vaginal bleeding, usually after 20 weeks. Risk factors. Prior C-section, prior previa multiple gestation, advanced age, multiparity, smoking.
Management.
Pelvic rest, no intercourse exams. Repeat US around 28-32 weeks, many resolve.
Yeah.
If persists, scheduled C-section, usually 36-37 weeks if asymptomatic. No digital cervical exams. Initial FHR, usually reassuring unless major bleed.
Cervical insufficiency. What is it? Risks.
Painless cervical dilation shortening, usually in second trimester, leading to preterm birth loss. Risks, prior painless loss, DES exposure, uterine anomaly, cervical surgery trauma, cone iliac laceration, short cervix on US.
Diagnosis and treatment.
Diagnosis often by history. TBUS shows short cervix, 2.5 centimeters. Exam might show dilation bulging membranes. Treatment. Circlage, stitch, placed around 12-14 weeks of history indicated, or later if US indicated short cervix. Vaginal progesterone can also prevent preterm birth in women with short cervix. No prior PTL history.
Cervical contamination, cone biopsy. Indications and complications.
For CIN-23, diagnose treatment after colposcopy. Risks for future pregnancy. Cervical insufficiency, preterm birth, PPROM, cervical stenosis. Observation for CIN2 might be option in young women desiring fertility.
Colposcopy in pregnancy.
Safe to perform. Biopsy abnormal areas, suspicious for high-grade cancer. Endocervical curettage, ECC, usually deferred. Goal is to rule out invasive cancer. Treatment of CIN usually postponed until postpartum.
HAL-LLP syndrome recap. What does it stand for? Liver issues.
Hemolysis, elevated liver enzymes, low platelets. Liver issues due to microthrombi necrosis and sinusoids, liver swelling, Glisson's capsule stretch, RU crepigastric pain, NV, risk of hepatic hematoma rupture. Delivery, definitive. Magnesium sulfate for seizure prophylaxis. Antihypertensives for severe BP.
Magnesium toxicity signs.
Antidote.
Loss of deep tendon reflexes,
Yeah.
first sign. Then respiratory depression, muscle paralysis, somnolence, visual changes, ultimately cardiac arrest. Risk increased with renal insufficiency. Therapeutic level 4 TAP7 MEQL, toxic 8 antidote, calcium gluconate.
Ectopic pregnancy. Risks and classic triad.
Risks: prior ectopic, tubal surgery, PID, IVF, IUD use, smoking, classic triad, unilateral abdominal pain, amenorrhea, vaginal bleeding spotting, positive beta-HCG.
Ruptured ectopic signs. Location.
Severe pain, hypotension, tachycardia, shoulder pain, referred phrenic nerve irritation from blood, urge to defecate, surgical emergency, most common location, fallopian tube, ampulla, others, corneal, interstitial, ovarian, abdominal, cervical.
Diagnosis and management.
Diagnosis: transvaginal US showing empty uterus plus adnexal mass-free fluid with positive beta-HCG, stop if above discriminatory zone.
Yeah.
Management: stable, unruptured, meets criteria, methotrexate. Unstable or ruptured, surgery, laparoscopy usually, salpingectomy or salpingostomy. Uterine inversion. Cause. Risk factors.
Uterus turns inside out. Cause: excessive fundal pressure or cord traction before placental separation. Risks: nulliparity, macrosomia, rapid labor, placenta accreta, mismanagement of third stage.
Presentation and management.
Severe pain, massive hemorrhage shock, round mass protruding from cervix vagina, uterine fundus not palpable abdominally. Management: call for help. Aggressive fluids blood. Immediate manual replacement. Fist and vagina pushing fundus up before removing placenta or giving uterotonics. May need uterine relaxants, terbutaline, nitroglycerin, briefly to aid replacement.
Water intoxication from oxytocin.
Oxytocin has ADH-like effect at high doses, water retention, hyponatremia, and seizures. Rare. Manage with hypertonic saline if severe symptomatic hyponatremia.
Oxytocin contraindications, indications, adverse effects.
Contraindications: situations where vaginal delivery unsafe, previa, prior classical CS, active herpes, transverse lie, fetal distress requiring immediate delivery. Indications: labor induction augmentation, PPH prevention treatment, adverse effects, tachysystole, hyponatremia, hypotension.
Late-term pregnancy, 41 weeks.
Risks:
Placental agent insufficiency, potential oligohydramnios, FGR, fetal distress, IUFD, also risk of macrosomia, get out difficult delivery, shoulder dystocia, birth trauma, maternal lacerations, C-section, PPH, fetal dysmaturity syndrome, increased surveillance, NSTBPP starting at 41 weeks, induction usually recommended between 41 and 42 weeks, delivery 43 weeks.
Postpartum urinary retention. Causes: presentation.
Inability to avoid UA6H's post-vaginal delivery or post-catheter removal. Cause: pudendal nerve injury, prolonged second stage, operative delivery, laceration, epidural effects in sensation tone, presentation, inability to void, overflow incontinence, palpable bladder.
Diagnosis and management.
Rice: post-void residual, PVR via scan or cath, 150 milliliter management. Intermittent self-catheterization until normal voiding returns, usually 1 week.
Perineal laceration degrees.
First, skin mucosa. Second, extends into perineal muscles. Third, involves external anal sphincter, 3A 50% AS, 3B 50% AS, 3C includes an internal anal sphincter. Fourth, extends through sphincter into rectal mucosa. Herb Duchenne palsy. Cause: presentation.
Brachial plexus injury, C5, C7 roots, usually from shoulder dystocia during delivery, macrosomia risk factor. Presentation: waiter's tip, posture arm adducted, internally rotated, elbow extended, forearm pronated, wrist flexed. Management: observation PT, most recover. Surgery if no improvement, by 3 to 9 most.
Fetal malposition, optimal versus others.
Optimal: occiput anterior, OA, malpositions, occiput posterior, OP, occiput transverse, OT, can lead to prolonged labor, arrestive descent, need for operative delivery or C-section. Molding kaput can suggest CPD.
Appropriate weight gain in pregnancy based on BMI.
Underweight 18.5, 28 40 pounds. Normal 18.5, 24.9, 25 35 pounds. Overweight 25 29.9, 15 25 pounds. Obese 11 20 pounds. Average caloric increase 350 450 kilocalorie in second third try. Inadequate excessive gain has risks.
Fetal anemia risks, quick hits.
Fetal-maternal hemorrhage, L-immunization, Rh, ABO, parvovirus B19. Note: FGR can cause polycythemia, not anemia. Gastrocesis risk with first try NSAIs. Menses return non-lactating, 10 WKs postpartum. Platelet transfusion threshold, maybe 20K for vaginal, 40-50K for CS. Beta-HCG undetectable, 2-4 WKs postpartum.
Routine prenatal screenings, key ones.
Initial: blood type or antibody screen, CBC, HIV, RPR, syphilis, HBsAg, Hep B, rubella varicella immunity, urine culture, GC chlamydia, ISPA 25 or high risk. Offer genetic screening, CFDNA, serum screens, 24-28 WKS, gestational diabetes screen, for an HRGTT, repeat CBC, repeat antibody screen if Rh neg, 35-37 WKs. GBS screen, vagal swab. Offer repeat HIV/STI if high risk. Anti-DI get 28 WKs if RH neg and postpartum if baby RHs. MSAFP screen 15-20 WKs.
Neural tube defects, NTDs, types, risks, prevention.
Anencephaly, encephalocele, spina bifida, myelomeningocele, risks, low folate intake, prior NTD, certain meds, valproate, carbamazepine, pregestational DM screened, all women, HIV, syphilis, Hep B at initial visit, high risk, 25, history partners, gonorrhea, chlamydia at initial visit, A&D, repeat all STIs in third trimester.
Syphilis stages briefly.
Primary, painless chancre. Secondary, rash, palm soles common, condyloma lata, lymphadenopathy, systemic SX, latent, asymptomatic. Tertiary, neurosyphilis, tabes dorsalis, dementia, cardiovascular, aortitis, gummas.
HIV management principles in pregnancy.
Goal, undetectable viral load via early ART. Monitor VLCD4. Avoid invasive procedures if VL high. Intrapartum. Continue ART if VL 1000, ART plus 5 zetavidine plus scheduled CS 38 WKs. If VLR 1000, ART plus maybe vaginal delivery. Avoid ROM scalp electrodes if possible. Postpartum. Mom continues ART. Infant gets prophylaxis. Zetavidine if mom suppressed. Multi-drug ART if mom VL high. No breastfeeding in developed countries.
Hepatitis C in pregnancy, key point.
Risks. GDM, cholestasis, preterm. Avoid ribavirin, teratogen, Hep A, B vaccines, okay? Vertical transmission risk correlates with maternal VL, CS, not protective. Avoid scalp electrodes. Breastfeeding, okay, unless nipples bleeding.
Fetal fibronectin, FFN.
Glycoprotein glue at decidual chorionic interface. Test cervicovaginal fluid between 22-35 weeks in symptomatic women. Preterm contractions. High negative predictive value, MPV. If negative, unlikely to deliver in next 1-2 weeks. Positive predictive value, PPV, is lower. Not useful before 22 WKs, normally high.
Short cervix management recap.
Found on TV US mid-trimester. If history of prior PTL plus short cervix, EBA 2.5 centimeters, circulage protagio plus metra and progesterone. If NO history of PTL plus short cervix, EBA 2.0 centimeters, seral progesterone.
EBS screening and prophylaxis.
Screen 35-37 WKs, VEG rectal swab. Prophylaxis during labor if GBS positive screen, GBS bacteriuria this pregnancy, history of prior infant with GBS disease, or unknown status, ND 37 Recaeus ROM 018 Rs intrapartum fever.
Antibiotic choices for GBS.
Penicillin G is first line, allergy, cefazolin if low risk anaphylaxis, clindamycin if susceptible high risk anaphylaxis, vancomycin if resistant or unknown sensitivity is high risk anaphylaxis. Give 4 hours before delivery ideally.
Braxton Hicks versus true labor.
Braxton Hicks. Irregular, infrequent, don't increase in intensity duration, usually resolve with rest hydration, no cervical change. True labor, regular, get stronger, longer, closer, cause progressive cervical change.
Prenatal genetic screening options.
First try, combined screen, HCG, PPPA, NT ultrasound, 11-13 WKs, or cfDNA, 10 plus WKs diagnostic, CVS, 10-13 WKs. Second try, quad screen, AFP, HCG, estriol inhibin A, 15-20 WKs, diagnostic, amniocentesis, 15-20 WKs. cfDNA can also be done second try. Abnormal screen offer diagnostic testing, CV Sanyo, or further screening, cfDNA, detailed US.
Want screen patterns.
Trisomy 21, AAFP, astrial, AACG, housomy 18, trisomy 18, AAFP, AACG, inhibitor variable, often normal, NTD abdowal defect, AAFP, others normal.
Cell-free fetal DNA, cfDNA indications.
Advanced maternal age, abnormal serum screen, U.S. findings concerning for aneuploidy, prior aneuploidy pregnancy, parental translocation, screens mainly for T21, T18, T13 sex chromosome aneuploidies, high sensitivity specificity, but still a screening test.
Acute cervicitis, presentation, clauses, treatment.
Presentation, mucopurulent discharge, yellow-green, postcoital bleeding, friable cervix on exam, causes. Most common, chlamydia trachomatis, Neisseria gonorrhea, also trichomonas, HSV, DX, methy testing, TX empiric treatment covering GCCT usually, ceftriaxone IM plus azithromycin PO or doxycycline PO. Differentiate from BV, thin gray discharge, fishy odor, clue cells.
Wow. Okay, that brings us to the end of an incredibly packed deep dive into obstetrics, really aimed at helping you get set for your shelf exam and Step2CK.
Yeah, we covered a huge amount of ground.
We really did. From those early physiological shifts right through to complex labor issues and postpartum care, connecting those dots, hopefully.
Exactly. And I think what really stands out is how interconnected everything is. It's not just separate topics.
Right.
Understanding the basic physiology of pregnancy and how it can sometimes, go off track is key to figuring out these conditions. Hopefully the vignette approach helps solidify those connections for you.
Yeah, seeing it play out clinically. Okay, so here's a final thought for you to chew on. We talked a lot about how the normal adaptations of pregnancy, things the body needs to do, can sometimes actually increase the risk for certain problems.
That delicate balance.
Exactly. Like increased blood volume is vital, but it also ups the risk for clots and postpartum hemorrhage. So how does thinking about that interplay, that balance between normal physiology and potential pathology, influence how you approach clinical decisions in obstetrics? Something to keep mulling over.
That's a great point. And definitely, we encourage you to go back over any areas we covered today that felt a bit shaky. Doing practice questions on these topics is probably the best way to make it stick. And please feel free to reach out if you have more questions or ideas for other deep dives.
Absolutely. Thanks so much for joining us for this really in-depth exploration. We truly hope it gives you a solid framework and boosts your confidence for those exams. Until next time.